Usually, when we talk about a medical diagnosis, there is this, I don't know, this expectation of visual precision, you know?
Right, yeah. Like seeing is believing.
Exactly. You break your arm, the x-ray shows that jagged white line, and the clinician points to it and says, there's the problem. It's clean, it's binary, it's comforting.
We do rely heavily on that visual confirmation. I mean, if we can see the pathology clearly, we feel like we can control it.
But stepping into ear, nose, and throat medicine just, well, it completely shatters that comfort zone.
Absolutely.
Suddenly, that x-ray machine is pretty much useless for half the conditions you face. And you're navigating this diagnostic landscape where, like, 2 millimeters of inflamed tissue can mean the difference between a mild cough and a catastrophic airway collapse.
It's a very tight space.
Right. So for anyone stepping onto the wards, whether you are a medical student prepping for an OSCE or a junior doctor taking your first night shift in the ED, or just a curious clinician, you really need a mental map of this territory.
You definitely do.
So today, on the deep dive, we are pulling the core clinical pathways from the textbook principles and practicalities of ENT. Our mission is to build that map for you, focusing on the hidden physiological triggers that turn, minor complaints into life-threatening emergencies.
And the key to surviving an ENT rotation, really, is abandoning the habit of just memorizing symptoms. You have to visualize the anatomy.
Right, because it's so interconnected.
Exactly. It's this highly compact region where respiration, digestion, neurology, and sensory processing all intersect in a space like the size of a grapefruit.
Wow, yeah.
So we need to look at the mechanical failures and the underlying physics of these diseases.
Okay, so before we can even think about looking inside an ear canal or assessing someone's hearing, we have to start at the absolute foundation of emergency medicine, which is the airway.
Always the airway.
Right, because if a patient cannot breathe, the rest of the physical exam is completely irrelevant.
Absolutely. And the clinical hallmark of an impending airway disaster is stridor.
That's that really harsh breathing sound, right?
Yes, it's a harsh, high-pitched respiratory sound. But you have to understand why it happens. It is literally the sound of turbulent airflow forcing its way through a critically narrowed upper airway.
Okay.
When you hear stridor, you are already behind. You need an MDT approach of multidisciplinary team immediately.
So you're calling everyone.
You're bringing together ENT, anesthesia, and critical care. And the patient must be kept nil by mouth, or NBM.
Right, because if the airway completely closes and they need an emergency surgical intervention.
You don't want anything in the stomach.
Exactly. Any food or liquid could be aspirated into the lungs. That turns an airway obstruction into fatal aspiration pneumonia.
Which is a nightmare scenario.
Yeah.
Now, the standard sequence to secure that airway begins with endotracheal intubation.
Okay.
But if there is massive laryngeal edema or heavy bleeding or a crushing tumor, the anesthetist just will not be able to pass the tube.
Right, the space is gone.
Exactly. That triggers what we call a can't intubate, can't ventilate scenario. And at that point, you must establish front of neck access, or O&A.
F&O. Okay, so what does that actually look like?
You take a scalpel and perform a cricothyroidotomy. You make an incision directly through the cricothyroid membrane in the neck to just bypass the upper airway blockage completely.
Man, that is a brutal but obviously life-saving pivot.
It is.
And that kind of structural collapse naturally leads us to blunt trauma. The laryngeal trauma grading system, Schaefer's classification, runs from type I to type V.
Right.
I always picture the larynx and trachea like the rigid rings of a heavy-duty vacuum hose. So type I trauma is just a minor bruise or a tiny mucosal tear inside the hose.
That's a great analogy.
But by the time you reach type V, the hose is completely snapped in half.
Yes. A type V injury is a complete laryngotracheal separation. The airway is physically disconnected from the lungs.
Oh, wow.
Yeah, that requires an immediate emergency tracheostomy and very complex reconstructive repair.
Yeah.
The patient will be in absolute terminal respiratory distress.
Okay, so moving slightly up the skull from there, the temporal bone presents a completely different kind of trauma risk, right?
Yeah.
Because it houses our hearing organs, the balance centers, the facial nerve.
It's very busy in there.
Yeah.
We classify these temporal bone fractures now as either otic capsule violating or otic capsule sparing.
Otic capsule, what exactly is that?
So the otic capsule is the incredibly dense protective bone surrounding the inner ear, so the cochlea, the vestibule, and the semicircular canals.
Okay.
If a fracture line violates that specific bony capsule, The structural damage instantly escalated the risk.
Yeah.
They're looking at sensorineural hearing loss, complete facial nerve palsy, and cerebrospinal fluid leaking out of the ear.
Because the fracture has breached the space communicating with the brain?
Precisely.
Clinically, I know you'd look for the battle sign, which is blood pooling and bruising behind the ear, or raccoon eyes from periorbital bruising.
Right, those are classic signs.
But here is where the treatment protocol seems completely counterintuitive to me. If a patient comes in with a temporal bone fracture, the protocol calls for high-dose oral corticosteroids, sometimes up to 60 milligrams of prednisolone for a week.
Yes, it does.
But wait, if we have a fractured bone, shouldn't we avoid heavy steroids? Don't they actively impede osteoblast activity and delay bone healing?
It's a great question. We actually prioritize the neural tissue over the structural bone in this case.
Really?
Yeah, the facial nerve and the vestibulocochlear nerve travel through the fallopian canal. This is an incredibly narrow bony tunnel within the temporal bone.
Okay, so it's a tight fit already.
Very tight. When blunt trauma occurs, the soft tissue surrounding those nerves swells. But because the bone of the canal cannot expand, that inflammatory swelling has nowhere to go.
Oh, so it just compresses inward.
Exactly. It crushes the nerves, causing facial paralysis and hearing loss. So the high-dose corticosteroids rapidly suppress that focal inflammation. They relieve the pressure inside the tunnel before the nerves suffer irreversible ischemic damage.
Wow, okay. So we literally sacrifice optimal bone healing to save the delicate wiring.
We do.
That makes perfect physiological sense. Now, once the airway is secure from structural collapse, the next immediate threat comes from things actively blocking the passage, specifically catastrophic bleeds.
Right. An epistaxis, or a severe nosebleed, is the most common visual emergency you'll see.
And where do those usually start?
The vast majority originate in Little's area on the anterior nasal septum. This is where a network of blood vessels known as Kesselbach's plexus converges just under a very thin layer of mucosa.
Now, the natural instinct for almost everyone is to tilt their head back to stop the blood from dripping out.
Which is exactly what you shouldn't do.
All right.
Because that forces the blood backward into the oropharynx. The patient ends up swallowing large volumes of blood, and blood is a severe gastric irritant.
Oh, right. So they get sick.
Yes. The stomach will rapidly reject it, leading to vomiting. Vomiting spikes the patient's blood pressure, which forces more blood out of Kesselbach's plexus and creates a high risk of aspirating the vomit.
That's a vicious cycle.
It is. The patient must sit upright, lean forward, and apply sustained direct pressure to the soft cartilaginous part of the nose to mechanically compress those vessels.
Okay, and while a nosebleed is common, a post-tonsillectomy bleed, or PTB, is terrifying.
Truly terrifying.
If a patient comes back to the ED days after a tonsillectomy, you're looking into the oropharynx for active bleeding, heavy clots, or tonsillar fossa that look excessively white and slopy.
Which indicates a secondary bacterial infection eroded the surgical site.
Exactly. And a post-tonsillectomy bleed can rapidly progress to hypervolemic shock, right?
Very rapidly. You must stop the bleeding immediately. We use 75% silver nitrate sticks, which chemically react with the tissue to create a localized burn, coagulating the blood.
Ouch.
Yeah. If that fails, we apply adrenaline to vasoconstrict the vessels or take the patient back to the operating theater for bipolar cautery.
Using silver nitrate and bipolar cautery on a spurting tonsillar bleed is essentially the medical equivalent of spot welding a leaky pipe under high pressure.
That is a very accurate way to describe it.
You are chemically or thermally sealing the breached vessel walls. But blood is one thing. If we're dealing with a physical obstruction, say, a swallowed foreign body, I imagine the sheer mechanical pressure against those delicate mucosal walls changes the triage completely.
It does, absolutely. Swallowed foreign bodies typically lodge in areas of natural anatomical narrowing.
Like where?
In the upper tract, they get stuck in the tonsils, the base of the tongue, or the piriform fossa. But if they pass into the esophagus, they halt at one of three classical choke points.
Okay.
The cricopharyngeus muscle at the top, the level where the aortic arch presses against the esophagus, or the diaphragmatic hiatus where it passes into the stomach.
And the major fear here isn't just that they can't swallow, it's the risk of perforation, right?
Exactly. The esophagus lacks a serosal layer that's the tough outer wrapping that most of the bowel has.
Oh, I didn't realize that.
Yeah. So if a sharp object pierces the esophageal wall, aggressive bacteria from the digestive tract leak directly into the chest cavity, causing mediastinitis.
And the mediastinum is the deep space with the heart and major vessels.
Right. An infection there spreads rapidly and leads to overwhelming septic shock. It has a very high mortality rate.
Which highlights a terrifying reality in ENT. An emergency you can see, like a spurting bleed, is often easier to manage than an emergency that is hidden behind tissue or bone.
Without a doubt.
And that leads us to infections that start common but spiral out of control. Let's look at acute mastoiditis. That starts as acute otitis media, basically a standard middle ear infection, usually in a toddler.
Right. It's predominantly seen in children aged 1 to 3, mostly driven by streptococcus pneumonia. Yeah. The middle ear space communicates directly with the mastoid air cells, which are this honeycomb-like bony structure right behind the ear.
So if the mucosa swells from the infection, it blocks that communication pathway.
Yes.
And that turns the mastoid honeycomb into a closed-loop pressure chamber.
Precisely. The infected secretions are trapped. As the pressure builds, it cuts off the microvascular blood supply to the bone. The bone dies, that's localized bony necrosis. Yeah. The delicate honeycomb structure basically melts down into a single large cavity filled with pus. We call that coalescent mastoiditis.
Well, what does that look like clinically?
You'll see a very toxic-looking child. The pus pushes outward, causing a boggy red swelling behind the ear. The natural crease behind the ear, the postauricular sulcus, completely disappears, and the pinna of the ear is actually pushed downward and forward.
Okay, now let's pivot to the opposite end of the age spectrum. Necrotizing otitis externa, or NOE. This is not just a standard case of swimmer's ear.
Not at all.
This typically strikes elderly, diabetic males with poor glycemic control.
Yes, because diabetes causes microvascular disease. It compromises the tiny blood vessels that supply the immune system's white blood cells to peripheral tissues.
Right.
So when the bacteria Pseudomonas aeruginosa infects the ear canal of someone with this compromised blood flow, the local immune response just fails.
Ew, it spreads.
Quickly. The infection breaches the cartilage, spreads to the temporomandibular joint, and burrows into the temporal bone itself. It becomes skull base osteomyelitis.
Okay, but since both standard OE and NOE present with a swollen, discharging ear canal, how does a clinician avoid misdiagnosing life-threatening osteomyelitis as a simple ear infection?
You really have to listen to how the patient describes the pain. The pain in necrotizing otitis externa is entirely out of proportion to the visible swelling.
Okay.
It is deep-seated, agonizing, unremitting. It literally prevents them from sleeping. And it completely ignores standard topical antibiotic drops. Plus, because the infection is eating into the skull base, it can envelop the cranial nerves, most notably causing facial nerve palsy.
Diagnosing that level of deep bone infection must require more than just an exam. You need blood tests like the ESR and CRP, which measure systemic inflammation.
Right.
But the imaging protocols are what's really fascinating here. You need a CT of the temporal bones to look for physical bone erosion, but you pair that with radionucleotide scans.
Yes, because the imaging tracks the cellular activity. We use a technetium 99-meter scan for the initial diagnosis.
Why technetium?
Technetium acts like calcium, so it gets absorbed by osteoblasts. It lights up areas where bone is actively trying to repair itself, highlighting the exact location of the osteomyelitis.
Okay, makes sense.
But bone repair continues for months after the bacteria are dead, meaning that technetium scan stays positive way too long to tell us if our antibiotics are actually working.
Oh, I see. So to monitor the actual active infection, you switch to a gallium or indium scan.
Exactly, because gallium and indium bind specifically to white blood cells and acute inflammatory proteins. If the gallium scan goes dark, the active infection is clear, even if the bone is still healing.
And clearing that infection takes a while, right?
A minimum of 6 to 8 weeks of aggressive, systemic intravenous antibiotics. Penetrating deep bone is incredibly difficult.
Wow. Okay, so having mapped out how to stabilize a collapsing airway, stop a catastrophic bleed, and halt an infection from melting the skull base, we transition to the elective clinic.
A slightly calmer environment.
Slightly. The most frequent complaint on the ward is hearing loss. And mastering its assessment relies entirely on understanding the mechanics of sound conduction.
You absolutely must differentiate conductive hearing loss, which is a physical-mechanical failure in the outer or middle ear, preventing sound waves from reaching the inner ear, from sensorineural hearing loss.
And that's the neurological damage to the cochlea or the auditory nerve pathways.
Right, and sudden sensorineural hearing loss, or SSNHL, is a hidden emergency. If a patient wakes up and suddenly cannot hear out of one ear, the neural tissue is actively dying.
Oh, wow. So just like the temporal bone fracture, they require an urgent high-dose oral corticosteroid regimen to salvage the nerve before the damage is permanent.
Exactly. Now, bedside assessment starts simply. We use free field testing. You stand behind the patient and whisper numbers and letters at 60 centimeters, then move to 15 centimeters.
That gives a rough baseline. But the tuning forks are where the physiological deduction really begins. We use the Rinn and Weber tests.
We did.
But I've always wondered, why do we specifically use a 512 hertz tuning fork? Why not a higher or lower pitch?
It is the perfect intersection of physics and human perception.
Mm.
If you use a lower frequency fork, say 128 hertz, it produces massive physical vibrations. The patient's skin and skull will actually feel the vibration before their ear actually hears the tone.
Which completely invalidates your test of their auditory nerve.
Exactly. But if you use a higher frequency, like 10 to 24 hertz, the sound waves decay too rapidly in the air and the tone dies out before you finish the assessment. So 512 hertz isolates the auditory perception perfectly.
That is so cool. So for the Rinn test, you strike the fork and press the base against the mastoid bone behind the ear, directly stimulating the cochlea through the skull. That is bone conduction.
Right.
Then you hold the vibrating prongs next to the open ear canal to test air conduction. Normally, the mechanical amplifier of the eardrum and ossicles makes air conduction louder than bone conduction.
Correct. So if bone conduction sounds louder to the patient, it means the mechanical pathway is blocked. That's a conductive hearing loss.
You pair that with the Weber test. You place the vibrating fork on the center of the patient's forehead. The sound travels through the skull to both cochleae simultaneously. If the patient has sensorineural hearing loss in their right ear, the nerve is dead. So the sound lateralizes, it sounds louder in their healthy left ear.
But if they have conductive hearing loss in the right ear, something counterintuitive happens. The sound actually lateralizes to the poor ear.
Wait, why would a blocked ear hear the tuning fork louder?
It's all about ambient noise. In a normal ear, the ambient background noise of the room enters the ear canal and partially masks the subtle sound of the tuning fork vibrating through the skull.
Okay.
But if the right ear is completely blocked by wax or fluid, it is shielded from the ambient room noise. The right cochlea is sitting in total silence, so it perceives the pure bone-conducted vibration from the tuning fork much more intensely.
That is fascinating. To get definitive objective data, though, we use pure tone audiometry and tympanometry. Let's look at how a tympanogram actually maps this out. It doesn't test hearing, right? It measures the acoustic impedance of the eardrum.
Exactly. The device inserts a probe into the ear canal, creates an airtight seal, and changes the air pressure from positive to negative while constantly playing a tone. It measures how much sound energy bounces back off the eardrum.
So if the middle ear is perfectly healthy and filled with air, the eardrum is highly compliant. It absorbs the most sound energy when the pressure in the canal perfectly matches atmospheric pressure right at 0.
That creates a high, sharp peak in the center of the graph, which we call a type A pattern.
But if the tiny ossicle bones in the middle ear fuse together a condition called otosclerosis, the eardrum becomes extremely stiff. The sound waves just bounce right back off it.
Yes. The graph still peaks at 0 pressure, but the peak is incredibly shallow. We classify that as a type A pattern for stiff. Conversely, if the ossicles are disconnected due to trauma, the eardrum is floppy and hypermobile. The graph spikes off the top of the chart, creating a type A pattern for flaccid or deep.
And if a child has glue ear, where the entire middle ear space is packed with thick fluid, the eardrum cannot move regardless of how much pressure you apply.
Right, so the graph draws a completely flat line, a type B pattern.
And finally, if the eustachian tube is dysfunctional and constantly sucking air out of the middle ear, the eardrum is permanently retracted inward. The peak of the graph gets dragged deep into the negative pressure zone, giving us a type C pattern.
Spot on. Once you identify conductive hearing loss, you have to look for the structural pathologies driving it. We mentioned acute otitis externa earlier, but if that external ear infection persists longer than 3 months, it becomes chronic otitis externa.
Okay.
At that stage, prolonged antibiotic drop usage usually alters the local microbiome, allowing a fungal infection or automycosis to take over. You will actually visualize fungal hyphae growing on the ear canal walls.
Oh, gross. But you clear it using microsuction to physically vacuum out the fungal debris, right?
Yes.
And if the canal is too swollen to accept medication, you insert an expanding earwick to draw the topical drops, like Otimize or ciprofloxacin, deep into the canal.
That's the standard. But the most destructive cause of conductive hearing loss is a cholesteatoma.
Which sounds like a tumor.
It does, but cholesteatoma is a non-malignant collection of desquamated keratinized cells. It's essentially a constantly growing sac of trapped dead skin cells inside the middle ear.
It's just skin in the wrong place. but it acts like a benign tumor mimicking a malignant one.
Very much so,
Huh.
because the trapped skin cells trigger an intense inflammatory response, releasing osteolytic enzymes.
Osteolytic, so bone dissolving.
Exactly. These enzymes actively dissolve the surrounding bone. The cholesteatoma expands, melting the ossicles, breaching the inner ear to cause extreme vertigo, and potentially even eroding through the bone into the brain cavity.
That definitely demands surgical removal. The two main approaches are canal wall up versus canal wall down. In a canal wall up procedure, the surgeon preserves the normal bony anatomy of the ear canal.
Right.
The anatomy remains intact, but because the surgeon's visibility is limited, there is a much higher risk of leaving microscopic disease behind, often requiring a planned second surgery.
Correct. A canal wall down procedure, on the other hand, relies on drilling away the back wall of the ear canal entirely. It merges the middle ear and the mastoid into one large open cavity.
So you can see everything.
Yes, it allows maximum visibility, drastically lowering the risk of the cholesteatoma returning. However, it permanently alters the anatomy. The open cavity requires lifelong cleaning in the outpatient clinic, and the destruction of the natural middle ear space leads to poorer long-term hearing outcomes.
It's a tough trade-off. Moving from the structural mechanics of the ear down into the neurology of the inner ear and the neck, we encounter symptoms that are notoriously vague but hide critical diagnoses.
Like dizziness.
Exactly. If a patient presents to the clinic complaining of dizziness, letting them use that word will send you down the wrong diagnostic rabbit hole.
You must ask them to describe the physical sensation.
Right.
If they feel unsteady, lightheaded, or like they are going to faint, that is presyncope, which is usually cardiovascular. If they perceive that the room is physically spinning around them, that is true vertigo. True vertigo implies a specific failure in the vestibular system.
And we differentiate peripheral vertigo from central vertigo. Peripheral vertigo originates in the inner ear. The hallmark physical sign is horizontal nystagmus, that involuntary side-to-side flicking of the eyes.
Right. The semicircular canals of the inner ear primarily wire into the horizontal extraocular muscles to keep our vision stable when we turn our heads.
Okay.
When the inner ear misfires, it drives horizontal eye reflexes. Peripheral vertigo comes on suddenly. It's often accompanied by hearing loss or tinnitus, and it is fatigable, meaning if you repeat the movement that triggers the dizziness, the brain adapts, and the symptom lessens.
Central vertigo, though, originates in the brainstem or cerebellum. The neurological pathways in the brainstem govern vertical gaze, so central vertigo presents with vertical or downbeating nystagmus.
Yes, and it is gradual, non-fatigable, and a massive red flag requiring a full neurological workup.
The most common peripheral cause is benign paroxysmal positional vertigo, or BPPV, caused by displaced calcium crystals floating in the semicircular canals. We diagnose it with the Dix-Hallpike test to trigger the horizontal nystagmus and cure it using the Epley maneuver to physically roll those crystals back into their proper chamber.
That's right. Tinnitus also acts as a vital clue. We divide it into subjective tinnitus, which only the patient hears, and objective tinnitus, which is a physical sound in the body that the clinician can actually hear with the stethoscope.
The major red flags requiring urgent vascular imaging are unilateral tinnitus or pulsatile tinnitus that rhythmically beats in time with the patient's radial pulse.
Never ignore those.
Finally, moving down into the neck, we have to look at head and neck malignancies, cancers of the oropharynx, hypopharynx, and larynx.
Historically, these were driven almost exclusively by heavy smoking and alcohol abuse. But the epidemiology has completely shifted. We are seeing a massive rise in human papillomavirus, specifically strains 16 and 18, driving oropharyngeal cancers.
Really? HPV?
Yes. The virus integrates its DNA into the tonsillar crypts, overriding the cell's tumor suppressor genes. Interestingly, though, these HPV-positive tumors generally respond much better to radiotherapy than smoking-induced tumors.
That's good to know. Regardless of whether it's viral or chemical, the absolute most critical red flag for a laryngeal malignancy is unexplained hoarseness lasting more than 3 weeks.
Yes, you cannot assume a patient just has lingering laryngitis. That timeline mandates an urgent cancer pathway referral to visualize the vocal cords.
Absolutely. Okay, so we've covered a ton of ground. Let's run a rapid-fire case study to lock these concepts in for you, the listener. Consider the mechanisms we've discussed.
Let's do it.
You are reviewing a 72-year-old male with poorly controlled diabetes. He presents to the clinic with unremitting, deep-seated left ear pain that prevents him from sleeping. On examination, the pain is severely out of proportion to the mild mucosal swelling you see in his ear canal. Standard topical drops have failed.
Okay, think about it.
Based on the pathophysiology, what is your top differential diagnosis? What is the most likely causative organism? And what imaging modality do you need to confirm the active cellular destruction?
So if you visualize the microvascular failure in his tissue, leading to necrotizing otitis externa caused by Pseudomonas aeruginosa, and realized you need a technetium 99-meter radionucleotide scan to track the osteoblast activity in the skull base, you have successfully connected the clinical presentation to the underlying mechanics.
You've moved from memorizing lists to actually understanding the disease process.
And that's the goal. The anatomy of the head and neck is incredibly compact. It houses our airway, our mechanism for eating, our hearing, our balance, and our ability to communicate.
It's basically everything that connects us to the world.
It really is. A pathology measuring just a few millimeters here doesn't just damage local tissue. It fundamentally alters the human experience. It severs the patient's connection to the outside world. Keep that physiological reality in mind the next time you pick up an otoscope.
A few millimeters altering the human experience. Keep analyzing those mechanics, and we will catch you next time on The Deep Dive.